Alors nous passons, comme Rosalie.
So as Rosalie just said, we are entering a new phase. It is the stage of the practical experiences that were developed over the years. And I have seen probably in your program, there's a beautiful text that reminds us that the difficult life conditions in which children are being born and growing has been a concern for the pediatricians since 1767, the year in which London's first clinic for poor children opened its doors. So less than a century later, social medicine made its appearance in literature in 1848. And at the end of the Second World War, the social pediatrics model started in Europe with pediatricians who took an interest in the social and preventive elements of child medicine. In Canada, the community social pediatric model was born in Montreal in the early 1990s. So we know through whom. And this afternoon, we will look at four different experiences and take advantage of those models. So let me first introduce Judith Lynam. Ms. Lynam, if you would please.
So I have 4 minutes to talk about what Richer is, and I just want to say that when we started Richer, and I'll explain what it is, we had the benefit of the work of Dr. Julien and the foundation here as a model and ideas to draw upon. So we took those ideas and tried to introduce them and create our own model with our own sets of resources. So Richer stands for responsive, intersectoral, interdisciplinary, child and community health, education, and research. So each of those words reflects principles that we try and uphold in the context of our social pediatrics model. So we started this with a conversation in 2005, and there was we drew upon the population health data that had been generated through the EDI, which Educational Development Indicator measure that is now used nationally. And this neighborhood that we're working in has 67% of the children were not developmentally ready for school at kindergarten. 70% of the families live in marked poverty. A third of the families in our neighborhood are Chinese immigrant families. A third are Aboriginal, urban Aboriginal families, and the third are just poor families. So we're working in a very ethnoculturally diverse context in the inner city of Vancouver, which we all know is very beautiful, but it has a very challenging neighborhood that we're working in. And we found, so what I'd like to tell you a little bit more about when we have a chance is how we found the partners and how we took this idea to create what is now quite a viable living model. And so I'll leave it there.
Good, thank you very much. Le docteur Andrew Aligne de l'Université de Rochester se passionne.
Dr. Andrew Aligne is fascinated by community-based pediatric health with research interests that include tobacco exposure in children and risk factors for pediatric asthma. His research on determining factors of child death health has been published in various journals around the world. He's the director of the Child Advocacy Resident Education and co-director of the Pediatric Link with the community. And Dr. Aligne has effectively integrated community pediatrics into residency training. He will be talking about his experience.
So I'm very happy to be here in this lovely Science Center. Last week I was at the Science Center in Rochester, which is not as nice as this one. And I went with a bunch of residents and medical students. And we got there, and the lady at the desk didn't know what to do with us because normally it's little children who come to the Science Museum. And she asked if I was the chaperone and told me, to watch them and make sure they didn't break anything. But we had a very good time, and the reason that we were there was that they had an exhibit about race and racism. And we walked around through there, and it was a very well done exhibit, and it talked about determinants of health, about how everybody learns in medical school in America that black people have more hypertension and asthma and low birth weight and other problems than white people. And then they explained in the exhibit why that was sort of nonsense in terms of how people think about race as a biological entity, and had very nice, clear science graphs that showed, for example, that people who are black in America have very high blood pressure prevalence, but people in Africa don't. And so it's not about race, whatever that means. And this kind of information about it's something other than race, it's something about the environment, it's something about where you live and what you do and how you live, was news to the learners that I brought with me to the museum. And these were people who've been through 4 years of college and some kind of a pre-medical curriculum, and have done, after that, 3 or 4 or 5 or 6 years of medical training, and they hadn't heard that before. And so our programs that we have, Pediatric Links with the Community and the Child Advocacy Resident Education Program in Rochester, they're about teaching residents, people who are learning to be physicians and other kinds of healthcare professionals, about stuff that you don't learn normally in medical training, about how health is more than medical care, because there's a lot more to health than medical care. I'll stop there for now. I can tell more about it.
Vous êtes très discipliné. You're very well disciplined. You don't want to speak too long, but we'll need to know a lot more about that later. Diplômé en médecine de l'Afrique du Sud, le docteur
Dr. Miriam Metar has had her residency in pediatrics at the University of Saskatchewan, and she's now a member of the pediatrics residency program, and she's also leading the social pediatrics division in Saskatoon that was established in 2007. The Department of Pediatrics established a partnership with the Greater Saskatoon Catholic School Division and the Saskatoon Tribal Council, and definitely a very interesting experience to hear about, to establish pediatric school-based clinics. Dr. Metar.
Thank you for having me. I'm going to start off by saying that whatever I say today certainly does not infer that we own the model or that other people are not doing this. In fact, we've learned a lot from people who has been doing social pediatrics for quite a while. I also want to acknowledge the Indigenous Mohawk clan mother who was here this morning. I'm from Saskatoon, and Saskatoon exists on land that was marked as it's part of Treaty 6, negotiated by treaties over 100 years ago. So school-based clinics in Saskatoon was established in 2007, and it was established after a health disparity report by Neighbourhood Income was published in the Canadian Journal of Public Health. The study was done in Saskatoon, which highlighted disparities that exist between populations who live in low-income Saskatoon and populations who live in high-income Saskatoon and middle-income Saskatoon. The school-based clinics came about to attempt to address these disparities, or at least try to attempt disparities, to address the issue of children's rights and health equity for all children. And what we were going to do, the first and foremost thing was going to provide access for children, for infants, children, and youth who live with families who struggle with issues related to poverty. As we heard this morning, by definition, that population of infants, children, and youth would be the population who experience toxic stress. Those would be the infants, children, and youth who live with families where the adults would score quite high in terms of their ACE scores, and also whom themselves are, as they are growing, subjected to ACE scores that will compound their ill health as they transition into adulthood. And also infants, children, and youth whose prefrontal cortices are not able to function as it should. The The model of school-based health actually came about after community consultation, and it was the community that said that the schools were a safe place for us to actually come in and to provide health care. The partnership came about through the Department of Pediatrics, and I'll talk a little bit later perhaps about why the Department of Pediatrics, the Saskatoon Tribal Council, and the Greater Saskatoon Catholic School Division, and why the partnership exists. And I'll stop there.
Alors, à vous la parole.
Thank you. I will try to make a place for myself. So I was told, so you're the only social worker. They're all physicians, so I try to be up to the task. So first, I would like to put some emphasis on the Montreal model and show the kind of approach that community social pediatrics is applying in both of our centers, where the intervention is egalitarian, so an intersectoral where everybody has a word to say with the most vulnerable families. Of course, you know that Hochelaga, Maisonneuve, and Côte-des-Neiges are the neighborhoods that are said to be vulnerable, and stats say that every second child is not ready to enter school. So there are major issues on which we have to work together. The approach that we defend is a proximity approach, but we're all working together with the children. So we'll be able to talk about it further in a moment.